I think I got it on my mobile. Right. Yeah, I will hand over to my co-chairperson, Dr. Vinay Kumar, if he would do the formalities of introducing our first speaker, Professor Anand Ramakrishnan. Sir, are you unmuted? He's not, I think. Okay. Dr. Chaudhary, can I start with Dr. Anand Ramakrishnan's CV, please, so that he can go ahead with the talk?
I think he has some technical problems.
Okay.
So that's what.
Anyway, I will introduce because I have it on my mobile now. So, Professor Anand Ramakrishnan is MBBS DPM, Medical Science from Clinical Psychiatry, MSc Geriatric Medicine, and an FRC Psych. He is the chair of the Royal College of Psychiatry Trent Division. He is a member of the Royal College of Psychiatrists Trustee Board and Council, member of the International Advisory Committee, past president of the British Indian Psychiatric Association, International Distinguished Fellow, American Psychiatric Association, Secretary Steering Committee of the UNESCO, Chair in Bioethics UK Unit, author of chapters in 2 international textbooks, and published articles in peer-reviewed journals in the UK and India. He is the Secretary General of the Indian Global Psychiatric Initiative, Life Fellow of the IPS, Life Fellow of the AIPI, Secretary of the World Psychiatric Association, Section on Developing Countries, Honorary Professor in Bioethics, SRM University, Chennai, India, Visiting Professor in Psychogeriatrics, King's George University, Lucknow, India, Visiting Professor in Psychiatry, Father Miller's Medical College, Bangalore, India, recipient of the Jutika Memorial Award and the Gold Medal for the Best Research Paper represented in the All India Inter-Railway Competition in 1994, and the International Leadership Award by the IGPI in 2013. That's a wonderful CV, and we welcome Dr. Anand Ramakrishnan, and he can go ahead with his talk.
Thank you. I'm trying to share my screen now. Please, let me see whether if you can see that.
Dr. Jyoti, Dr. Vinay Kumar has also joined.
Okay.
He's unmuted. He's unmuted himself.
Okay, so as sir is presenting his PPT, does Dr. Vinay Kumar want to add anything? Welcome, sir.
Right. It's unmuted. Dr. Vinay Kumar. Oh.
Okay.
I'm sorry. Dr. Ramakrishnan, I think you please go ahead.
Thank you. Good morning from the very cold Great Britain, which is outside is 2 degrees just now. And thank you for inviting me to have a presentation today. And when I am doing this one, my memory goes back to many years ago when I was the organizing secretary of Association of Industrial Psychiatry of India. Sorry, can you hear me?
Yes, you are audible, you are clear.
Okay, right, thank you. When I was the organizing secretary for Industrial Psychiatry of India at Chennai, then Madras.
Oh.
And because of that...
इसको बंद करो सुरती, सेशन शुरू हो गया. हाँ. Yes, sorry for the interruption, Dr. Ramakrishnan. Your slide actually came on now. So please go ahead with your...
Okay, right, thank you.
Very sorry for this.
Okay, let's talk about we're talking about the shift work mainly. As you know, shift work is pretty prevalent in almost all the nations in the world. About 15 to 20% of the employees are estimated to utilize shift work system in industrialized countries worldwide. According to the data from the Occupational Health Survey, that is in the US, about 29% of, sorry.
So please continue.
29% of all the US workers in, Yeah, thank you. In 2010, worked on alternative shifts, and 15% of the workers regularly worked in night shifts. In Europe, it is about 1 in 5 workers engaged in any type of shift work that involves night work, and 1 in 10 workers has more than 5 night shifts per month. In NHS, which is National Health Service, the rotational shift workers account for more than 1/5 of the NHS workforce. The 2003 staff survey revealed that shift workers had negative experiences like poor work-life balance, less team working, and less job satisfaction compared to the non-shift workers. They are up to 7 times more likely to experience violence and also more likely to see errors and incidents. Incidentally, I'm happy to share my slides to the delegates if you want it, because that is why I've added more information in the slides. So I may not be able to go through every point, but it will be useful if somebody wants to read that later. The mental health of the doctors, that is, the British Medical Association conducted a qualitative research in 2019 in 2 stages to find out what are the mental health issues of the doctors in the United Kingdom. And they came up with about 5 different risk factors, which are systemic factors, issues which result from poor process and systems, including understaffing, because there's about quite a significant deficit of consultant and junior doctors at the time. And there's understaffing and rota gaps and lack of flexibility and poor work-life balance, demand in primary care, pressures to discharge patients in the secondary care, and increased regulatory fears. And there are endemic factors, which are learning to cope with effectively the clinical risk, dealing with the traumatic events and unexpected outcome, which are probably common all every part of the world. But there are interpersonal factors like hierarchy and bullying, the stigma around mental health, erosion of peer support networks. The environmental factors are practical issues often linked to the workplace, lack of amenities, breaks, and having proper parking facilities, changing rooms. That is again, which is becoming more apparent during the COVID pandemic, because we are expected to go to hospitals with our own clothes and then change to the uniform and also PPE in the hospital. But unfortunately, many people find it difficult because they have to do it in the toilet. And there are socio-cultural factors like the rise in patients' self-diagnosis and increasing patients' expectations. And there is an NHS constitution which gives much more powers to the patient to know what they have, and for the doctors and the medical profession to cooperate with the patients much more than in the past. There are potential drivers for deterioration in medical professionals' mental health. For example, systemic changes. There are working patterns, less autonomy, and much more administration burden. So unless that has changed, it will be difficult for them to improve. Then support to face endemic challenges, like they are getting less and less peer report. When people like me joined the National Health Service, we used to have something called Doctor's Mess, which provided a lot of support where we could go and discuss with your peers about cases, issues, and there used to be a lot of support, which are currently, it doesn't happen. So that is a lot of difficulties in that way. Then promoting camaraderie. Some places they have mental health buddies to support people having mental health issues and reduce stigma of mental health. And they thought that more information on talks on mental health issues during induction and also during their career and during the curriculum also, it would be useful. Environmental improvements like protected breaks and supporting facilities could be helpful. Responding to sociocultural change like positive public opinion erosion of professionalism, which is happening, unfortunately. Then they made 5 recommendations. They thought BMA and other organizations continue to work to lobby government to protect the long-term interest of doctors, and develop and promote a wider well-being charter to generate commitment to providing healthy, happy workplaces. The BMA and other key medical professional bodies all have a role to play in terms of raising awareness and signposting. Impartial BMA resources such as well-being services confidential helpline is popular. Junior doctors and students appear more inclined to engage with the subject of mental health in the workplace. And the health effects of shift and night working, the individual effects are fatigue, slow, especially slow reactions, increased errors, difficulty in concentrating, frequent lapses in attention and memory, irritability, increased susceptibility to gastric disturbances and gastrointestinal disorders, higher incidence of cardiovascular diseases, negative effects on relationships, anxiety and depression. Then organizational effects like increased sickness absence, reduced productivity, increased ill health retirement, and higher levels of staff turnover. The changing minds at work which can happen to support people at work would be a supportive work environment that can reduce the onset, severity, impact, and duration of mental health issues. A work environment characterized by trust, feeling valued, and fairness, and clear leadership and expectations, and being civil to each other, and having mutual respect, opportunity for career development, engagement and support, and then also there will be physical and psychological safety. Researchers examined data from 7 previously published studies and published in American Journal of Public Health in 2019 that showed that mental health involving a total of about 28,438 participants. The overall shift workers were 28% more likely to experience mental health problems than people with consistent weekday work schedules. Compared to women who worked consistent weekday schedules, women who worked nights and shifts were 78% more likely to experience adverse mental health outcomes. Men, however, did not appear to have an increased risk of mental health issues. The sleep-wake cycle disruption can make people moody and irritable and lead to social isolation as shift workers, time of matches, family and friends work and life commitment. Shift workers were 33% more likely to have depression than people who did not work at nights or irregular schedules. This shows that as the people work for longer hours, the mental health issues also increases. The relationship between shift work and mental health, which was studied in a South Korean electronic factory with about 14,000 employees. They focused the data on related to shift work and mental health. Insomnia, depression, and suicidal ideation were set as dependent variables on working schedules set as independent variable. Related to daytime workers, shift workers had greater odds of insomnia, depression, and suicidal ideation. And the numbers there are the odds ratio. Within the shift worker group, odds of depression and suicidal ideation increase dramatically when respondents had insomnia to 4.9 and 7.9 respectively. If people want to have a good idea about sleep and what is it for the brain, there is a good YouTube video I would recommend for watching it because it gives you some good idea about and also dispel myths around sleep. We talked about fatigue, a physiological state of reduced mental or physical performance capability results from sleep loss or extended wakefulness, circadian phase, or workload. The sleep deprivation can impair a person's alertness and ability to work safely and effectively. And how you can manage fatigue. You can limit the working time, and also you can have certain support mechanisms which can be useful to all the shift workers, and how you can manage fatigue and how it can be understood and managed with the help and support and engagement, and measure and manage actual fatigue levels and the risk what it produces. Managing sleep opportunities, how fast is sleep debt building up? So that is what happens if you don't sleep, the sleep debt, the REM debt builds up, which is creating all the other problems of circadian shifts. And how long since 2 full nights of sleep in a row? So that is also what it is useful to know. Managing risk at work, how tired are staff going to be on the shift? How difficult are the work demands and conditions? How long should they keep going, getting people home safely? Managing work-life balance, each person reacts differently. Regularly, predictable work patterns help time management. Fair distribution of weekends off and staff input in roster design and management also helps. Sleep and health, shift work restricts sleep, and the population-based studies have shown that less than 7 hours sleep increases possibility of obesity, impaired GTT, and type 2 diabetes, cardiovascular disease, poor general health, and premature mortality. Experimental sleep restriction studies also showed that there is increased calorie intake, decreased physical activity, and altered thermoregulation, impaired glucose metabolism, increase in blood pressure, and sympathetic nervous system activity. And it is a physiological challenge because the light-sensitive circadian pacemaker in the suprachiasmatic nucleus does not adapt, that contrary to many people's belief. Trying to work when least functional, which is creating issues, and eating at physiologically inappropriate times, trying to sleep when primed for a wake up, and also sleep at nights, not a social convention. So that means when you're doing shift work, you're displacing the sleep. This is how you are sleeping well. These are obviously common ideas which people ensure do it to ensure that they have a proper sleep. And long hours and the safety when compared to the long hours, study of about more than 11,000 nurses, which showed that, as you can see here, the odds ratio of risk, it increases when you work longer hours. But coming out to the junior doctors, they had to comply with the European Working Directive from 2003. That means they used to work about 58 hours per week before that, and it was brought down to 48 hours in 2009. But in contrast, in Australia, the trainee working hours are not restricted in the legislation. Junior doctors commonly go through 7 shifts per month without drinking enough water and 4 shifts per month without having a meal. Then sleep disturbances induces increased cholesterol level by NR1D1 mediated CYP7A1 inhibition. This is an article in Frontiers in Genetics, December 20. You can see that disturbance in the sleep is associated with the increased rise of metabolic diseases, and sleep deprivation increase serum cholesterol levels, and warning signs of cardiovascular diseases, that is decreased high density lipoprotein, cholesterol, and increased corticosterone and 8-hydroxyguanosine level and hepatic cholestasis were observed after sleep disturbance. There is bile acid synthesis was more vulnerable to sleep deprivation than cholesterol synthesis. Sleep deprivation induced warning signs of an increased risk of cardiovascular and hepatic diseases. As you can see, NR1D1 deficiency could also further increase serum cholesterol level, and the tendency of cholesterol accumulation in the liver under sleep disturbance conditions increases. There is an increased serum and liver cholesterol level induced by sleep disturbance is an early pathological event. And this finding explained the important role of circadian clock in linking sleep loss and lipid profile abnormality. Reducing stress and burnout in junior doctors, the impact of debriefing sessions. In their work in Australia, they found that when after one shift, if there is a debriefing sessions, the burnout is much less. And the burnout can directly affect the junior doctors and potentially patient care. It affected up to 68% of the doctors in their first year of internship, with higher representation women than men. An intervention in the form of debriefing sessions aimed to reduce prevalence of burnout and was well received by the cohort, with 90% concluding that it was a good source of emotional and social support for them. The female interns experienced higher levels of burnout, but no association was shown with age, current term of hours worked. There is no causal relationship between burnout and demographic factors. Results of a larger study showed that internal medical female residents demonstrated higher levels of emotional exhaustion and depersonalization than men. Health consequences of shift work, which compared linked to the insufficient sleep. This review summarizes the literature on shift work and its relation to insufficient sleep, chronic diseases and accident. It is based on 38 meta-analysis and 24 systematic reviews, with additional narrative reviews and articles. The effect of shift work on sleep mainly concerns acute sleep loss in connection with the night shift and early morning shifts. There is a link with shift work and accidents, type 2 diabetes, weight gain, coronary artery disease, stroke, and cancer. The laboratory studies also indicate that cardiometabolic stress and cognitive impairments are increased by shift work as well as by sleep loss. The effect of night shift rotas of junior doctors. This is slightly different from in the Indian context, but still, I think the basic issues remain probably the same. The thinking becomes slower and more sluggish, reaction times become slow, the judgment falters, and you may risk your decisions. You will tend to perseverate to continue to do things which aren't working well, probably because you may not know that. Your sense of empathy critical to delivering good care to your patients may become blunted as your levels of fatigue rise, because you could become more annoyed easily. Your ability to deliver safe, effective, efficient care to your patients begins to drop sharply. And this means that paying attention to staff fatigue is critical, delivering patient care appropriately. The knife to working without breaks can increase risk of harm both to patients and to yourself. You should expect to get about 2 30-minute break during every shift of 9 hours longer, and at least 75% of the time. This is as per the 2016 Junior Doctor Contract in UK. There's a campaign in one of the London Trust called Halt, Take a Break to make people aware of this. And when you drive home after a night shift, the levels of fatigue commonly experienced produce similar effect on your driving ability as if you are driving at a legal drunk drive limit. This is a newspaper article from a daily record after crashing on the way back home because she could not concentrate and she staggered and gone to the wrong way, and she was fined by the judge. A national survey of effects of fatigue in trainees in anesthesia by the Royal College of National Association of Anesthetists showed that fatigue remains prevalent among junior anesthetists, with the reports that it has effects of physical health, psychological well-being, and personal relationships. The problematic factor remains night shift work due to absence of breaks, adequate rest facilities, and 57% stating that they had experienced an accident or near miss when traveling home from effects on their physical health or psychological well-being and personal relationships. The Royal College of Physicians guidance for their junior workers about how they can cope with the night shift is mainly how they can prepare before the night shift and how they work during the night shift, having a regular naps. They would drive home, are they fit enough to drive, what they do when they get home, and how they will manage their sleep. And there are some factors which probably adversely affect women. Going to plan the domestic affairs, compulsory weekend working, which will be difficult for them, and early start or late finish also difficult because of the child minding issue pattern evolves. The physicians in 2016 did a survey of junior doctors to find out all the issues, and the story of a professional under pressure. That was their comment. It is a warning that patient safety is at risk and a call for action. The higher specialist trainees and core medical trainees participated in this working in a clinical post. They said that the work is quite intense. That is 7 out of 10 junior doctors work in a rota that has a permanent gap. Junior doctors commonly go through 7 shifts per month. Often without adequate breaks or having anything to eat or drink. Excuse me. But they felt that it is rewarding because majority felt valued by the patients they look after, although they don't have enough time to see them. And they said it's challenging that 4 in 5 junior doctors regularly experience excessive stress because of their job. 6 out of 10 junior doctors report that patient safety is being put at serious risk due to poor hospital services and a shortage of available hospital beds. Half of junior doctors felt that hours were much longer. As you can see, 90% in 1 hour, 81% 1 to 2 hours, and 46% more than 2 hours. Just 2-3 minutes, is that okay? Then preparing for the night shift, maintaining good core sleep routine should be there, and then during the night shift, how they can support. It is just like what I mentioned before. And after the night shift, if you are too tired, don't drive, which is very important because for your own safety. And use public transport wherever possible, and avoid alcohol and nicotine and caffeine. And what could employers do to help? This could improve, including teaching and induction of all trainees on sleep, shift work, and fatigue, adopting positive attitude to shift working, particularly at night, and then provide appropriate rest areas and facilities, appropriate overnight, and allow staff to power nap during breaks if they choose to have it. And I think I would stop there because the time is up. And if there is any questions, I'm happy to take it. Thank you.
Thank you, Dr. Ramakrishnan. Are there any questions? I think I will ask the organizers. And Dr. Vinay Kumar, can you? Sir, you are still muted.
I think there is some difficulty with his microphone.
Yeah. Yeah. he able to come in? No. And that was an extremely exhaustive presentation. Thank you, sir, very much. Actually, I had a question because we all have been doing COVID duty and we all have all our junior residents who have been round the clock on duty. Unfortunately, at least at our center, we've not had any sort of debriefing sessions as such. And what they usually have is a training session on the basics of donning, doffing, and what precautions they have to take, and basically how to take care of their mental health. I mean, just a talk basically. There have been a couple of students or residents who have, and some of the mental health professionals and other health professionals who have sought help. More for anxiety and sleep related issues, but then it was very nice that you said that you'll have it in an SOP, which I think should be there, but we have not obviously employed it. So what has been your experience with in regards to how this is done in terms of like the debriefing? Do you do it in groups, or is it something that is done at an individual level?
It used to be very systematic before, but after the excuse me, the COVID issues, things are splintered, because unfortunately people do not meet that much because of the the social distancing and also the PPE difficulties, and so actually it is not very good now. But at the same time, this is actually really needed now, because people do not see each other. And they don't even see their smiles because of mask all the time. You don't see your people's faces properly. And actually, this is useful. How they used to do that, the handing over, because there is a lot of community work in the UK, that not all your hospital based, people usually don't see personally. But what they used to do is they used to hand over. They have a software that you use to hand over and raises any issues or any difficulties or cautions about any patients or anything what is happening in that software, so to be handed over to the other person. And they have a mutual communication, probably not all the time talking, but because the way it is practiced here, because the community systems, the people are in different places, probably miles apart. So that is why they can't meet. But hospital people, that used to be much more prevalent before. That's why I said when there's a doctor's mess, where there or doctor's room was there, people used to meet there, have a chit chat, at the same time, exchange ideas, and also have a peer group discussions, which is not much happening now, because most of the doctors, all the rooms are being taken off because of the way the things have progressed in the last few years. But the studies have shown that definitely the debriefing is quite useful.
Yes. Okay. Thank you, sir. Thank you very much. Are there any questions? I think Dr. Vinay Kumar wants to say something or ask something, but he's not.
So sorry, I think he's.
Is it possible for the organizers to unmute him at their?
I think he has unmuted, but there is some. No, he's still muted.
He's still muted. Yeah. Okay.
Am I audible? Yes, sir.
Is it possible to unmute?
No, ma'am, I'm really sorry. It's not possible from our side to unmute.
Okay. Guest. Are there any questions? Because I can't see any questions now on my chat. So, thank you again, Professor Anand Ramakrishnan. And if there are no questions, organizers, can we go for the next talk?
Definitely, ma'am. Definitely.
Okay.
Thank you very much.
Okay. Thank you again, Dr. Anand. Yeah. Thank you.
What's right?
Yes. Organizers, has Dr. Vinay got unmuted? Sir, will you take over?
Ma'am, I'll just, yes. So the next speaker we have for today is Dr. Kalpana Srivastava, who is a scientist DRDO from the Defense Research Development Organization, Department of Psychiatry, AFMC Pune. Her academic qualifications: she is an MPhil in Medical and Social Psychology from the Central Institute of Psychiatry in Ranchi and a PhD from Ranchi University. Her academic contributions are that she has completed more than 20 major research projects. She has 148 publications, 7 of which are international. She has edited 6 books and she has contributed to 9 chapters in books. Her honors and awards are as follows. She has been the Chief of Army Commendation Card in 2011 for meritorious service in the Army. She has been the President in Indian Association of Clinical Psychologists. She is the Vice President of AIPI. She is the Honorary General Secretary of IACP and the Editor-in-Chief of Industrial Psychiatry Journal till 2020. She is the recipient of the Gayatri Gopal Award of AIPI 2015, and she has done an oration of IACP for contribution in the field of clinical psychology 2013. She has received the Marfetia Award of IPS 2009 and the Kirpal Singh Award 5 times. She has also received the Shanti Niketan Mental Health Award and the Dr. G.C. Boral Award from AIPI. Her special interests lie in community outreach programs and positive mental health.
This crop is called hyenas.
So we welcome Dr. Kalpana Srivastava, and Dr. Kalpana will be speaking on digital technology and psychological interventions, new frontiers in mental health.
Thank you very much for this opportunity to be speaking to. Of course, I have a little rejoinder. Actually, the topic was changed to telecounseling skills, challenges, and perspectives. I thought, so a little update on that account. I would be covering this topic instead of digital technology interventions. However, touching upon the newer frontiers, telecounseling has seen the exponential growth in the recent past. So we'll be covering certain aspects which are very important and need to be sensitized and trained into. Very good afternoon, rather, to everyone. And this session has been having a lot of important discussions on very important topic. In the background of the pandemic COVID-19, tele-mental health services cannot be ignored. Rather, it should be emphasized that it has seen the new aspects and more uses in the recent past within a year, time span of 1 year, I would say. Telehealth is what? It refers to the use of telecommunications and information technologies to provide access to health information and services across a geographical distance. Now, what is important in this aspect is to focus on the geographical distance. See, when you talk about the mental health delivery, most of the time when you find there's a hurdle or there's a barrier that comes as a distance in terms of approaching, in terms of traveling, in terms of reaching out, that how to approach. This telehealth dimension, especially the technology interface with the mental health delivery, has mitigated that stress and also bridged the gap between the provider and the user. Provider means the person who's a mental health specialist and the user is a client. Technology counseling has seen upsurge, but there are certain challenges. So during the course of my talk, I'll be talking about certain challenges and perspectives as well. It is technology is just not included, limited to telephone calls, like landline, cellular, smartphone. We see the text messaging, chatbots, and the various types of web conferences, video conferences, virtual reality, avatar, the animation version also providing a therapy, virtual reality. So there are a lot of variations. Telecounseling is one aspect of the technology interface. When we go about the changes, what has occurred is in the telecom, this by virtue of being available to everybody in terms of the metros or non-metro cities where the internet facilities may not be available. So it becomes a limitation to have the access to internet and have an accessibility to the therapist or a health provider. But telecommunication is a far-wide network across the country, eases out that problem, and one can have an access to helplines through any committed landline or the mobile phones, which in India has again risen from quite a number of users are available at the moment. So when we say intervention, what it covers intervention, consultation, supervision, education, information, and it can be clubbed with the chat rooms or the email, or there could be instant messaging as well based on the telecommunication. So when we have a committed, for example, space where it has been provided that this is services taker is going to use this particular number or this particular space, one can have the messaging, and that also helps apart from the telecounseling. So what are the types of helplines or the telecommunication which is available? There's a classification of this. One is known as a warm line. Warm line means less than life-threatening topics can be discussed. Then there's a hotline. Hotline here means the person having a threatening or endangering topics. It could be domestic abuse, substance abuse, suicidal, etc. Time-limited hotlines are like for the disaster relief, some period of time. We might have seen, and we have provided the helpline, especially during the pandemic also, as a time-limited hotlines. So we used to have, or during the COVID-19 period, this service will be available from this time to this time, and there will be therapists who will cater to the individual needs. This is known as time-limited hotlines. Then the continuous national hotlines. So we see that in terms of the various kinds of toll-free numbers, which are, I mean, the government has thought about that. And for the mental health, they have promoted or rather launched a Kiran helpline, which is for the disabled and especially mental disability to give the support and access to the services of a psychologist, a trained clinical psychologist. So there could be these kinds of various approaches which can be useful in the helpline and telecounseling. What are the barriers in this mental health care delivery and how this is a boon? Let's just think about this or recapitulate. See, when we talk about the mental health delivery or we talk about the access, transportation becomes a big issue, especially somebody has to travel from the far off places to see the doctor, see a therapist. Need for childcare. If there's a time, no care provider available, leaving the person behind, leaving the old age person behind, bringing the child is also becomes a problem. There's a stigma, of course, which we all feel that a lot is required to be done to going to the psychiatrist or a clinical psychologist. Leaving work becomes a problem. Like, for example, I'm sitting here till 4:30, 5 o'clock, and I have to see a therapist at 5:30. It becomes difficult. How do I reach? So if we have a telecommunication, teletherapy, or the digital framework or any kind of a technology-based interventions, it is a lot easy. One can have an access within the short constraint of time. Hence, telephone-delivered psychotherapy can minimize such barriers and mental health care delivery. And everything does not come only with the merits. There would be certain demerits as well, but we need to transact and navigate and maybe overcome those demerits and try to be as trained as possible as to how to handle these challenges while delivering on the telecounseling. I was told that the time is less, so I'm looking in the watch at what speed I have to acquire. So when you talk about telecounseling skills, this involves interpretation, confrontation, exploring the problem. I'll here by bringing in another aspect that many a times telecounseling is being used rapidly by untrained professionals also. Now, this is because in India, there's legal aspects of regulating any kind of a mental health support system and mental health services is not so much well in place. So though NIMHANS has released the guidelines of the telepsychotherapy, wherein the telecounseling and telepsychotherapy used interchangeably, but it becomes a process where one aspect has got the more weightage. Like, for example, telecounselors will be many. They would not even consider that this needs particular amount of training, masters, beyond masters and orientation training, and the training to execute. So this is a challenge for us. Now, this in terms of the options which are available and how one should go for it. So goal setting, encouraging the person, training are the various aspects involved in this. Now, skills of telecounseling are not so different. They are part of the counseling skill also. But what is required is to have more nuanced conversation, ability to handle some of the aspects, which I'll be touching upon during the course of discussion. See, one has to have the understanding of paraphrasing, reflecting, feeling, and content when we are handling the telecounseling. Then relationship, trusting relationship, maintaining open communication is applicable like it is applicable in counseling as well. Then boiling down to the problem to discover solutions by clarifying what issue the caller would like to focus on. This has to come as a skill. For example, if somebody is talking to us over from the other end on a on a telephone or telephonic communication, it may not be the person is not visible. His voice is there, you're attending to. His nuances are not visible. His pitch, tone, voice is the only thing which is available to you for the analysis. Sometimes there will be a tendency to speak more. So it is important to bring it back to the focus as to what is required to be addressed. There should be a training imparted rather for the telecounselors. It is important to know that structuring of the interview is important in such a setting if they are engaged with the telecounseling services. Problem is the activity, exploring a problem situation. They have to give specific training in the skills of effective advice giving, which should be analysis based and it should be based on the individual orientation both. So analysis is a very important component of it. At the same time, there should be a role play of the crisis callers. If somebody has to really face a crisis caller, how would the person would respond? So the impact of counselor's response, one can understand once the person goes through that the crisis call has to be attended like this. So over and above these skills which are required for the counseling, telephone counseling requires the person to be having an apt voice tone, pitch, speed, and emotion in terms of understanding these aspects. Use of silence. If you ask a question which pertains to the emotional component of the individual, they just may not respond immediately. So one should know how to dwell in the silence and how to carry forward the silence. So to nuances of tone, language, handling silence are important component of telephonic counseling. Like we have the trust. Trust means the person is not visible. The caller may be identified as a caller who has introduced himself or herself as such. So it needs a trust to the person who's talking to. It is applicable both ways. It is applicable for the person on the other end and for the therapist, that there should be a trust when you are calling. So there's a lot of documentation which is being advised in the telecounseling. The clarification, exploration as to what more is required to be done, commitment, how many sessions, with the prior appointment, with the duration, with the timing, like we have as a practice. And the closure, when we even the session closure. For example, if you have 45-minute session and you're reaching up to 40 minutes, it is a common sense, but common sense also becomes uncommon sometimes in practice because the person is talking about emotional content. You may not like to pitch in and say, now time is going to get over. So it's much better a practice to keep a watch. Of course, we do that. And 10 minutes before we say that we have 5 more minutes to go or 5 more minutes to go, so that it makes a person ready to wind up or to take on whatever is required to be taken on in that session with limited duration of that time available in that slot. So in the telephonic counseling services, what is required is a psychological contract, non-judgmental, credible connection, defining the problem as to what has happened, why the person wants to meet or seek help, safety in providing support, and alternatives. Sometimes it may be required that more contact with a physician, with a psychiatrist is required over and above telecounseling. So one has to make a plan and take a commitment. If a need arises, the person is willing to go and meet someone to seek help. Sessions are to be only conducted on appointment basis. Please remember, whenever there's a sanctity of any delivery of therapeutic process, it is important to have an embargo on time and the sessions. If we do not follow that, it becomes difficult to maintain, especially not the flow, also the commitment of the client. And appointments can be fixed by text message or email. That is done in the telecounseling services. Now, when you say the reasonably private and quiet space for session for both therapists and clients, It is noted that when people are talking, because it is not visible, there could be 10 people sitting in the room, there could be other people doing something on the work, and you may be on a speaker phone, the person may be talking to you. So it is required to ensure that when you are talking, how it is so difficult to ensure though, but it is required to assure that when we are talking on a therapy session, there should be a private space. It should not be heard. It should not be in the middle of any group, in the middle of any meeting. Then only one can talk freely, and this can be helped. So these are some preconditions which are required to be met before we take a client board on. Now, an ability to where the ability is working, especially, is the skill of the counselor. So I call it therapist because the words interchangeably being used, therapist and a counselor, they both need a qualification, they both need a certification. So in terms of counseling, the degree at least is required. So there should be a skill to add on, especially knowledge to make the effective use of the medium, and knowledge of the concerns as to how to handle the concerns of the client or a patient. Now, initiation of session. Initiation is very important, so you always remember that callback time to be specified, and is there any technical problem, it has to be sorted, and to resume the call in terms of the, especially when there's a technical problem, it can be postponed to another date with a mutual consent. Intake session, this is important. Many a times we do not verify the documents of the person who's calling. When the telecounseling started happening, it was a very important component that take the documentation of age, identity through government recognized identity documents during the intake session. This can be actually shared either on a mail or on a text, especially on a telephone, as per mobile phones. Is unable to provide a proof of identity documentation, may be called for in-person evaluation. So it is important for a client or patient to have the therapist identity and therapist to have the patient's identity, both ways. Documentation of identity proof is necessary. Otherwise, it can lead to a lot of different kind of ramifications and repercussions, which will be difficult, because there could be people who will be talking when they will not reveal their identity, and you are giving an age appropriate therapy. They are talking age appropriate content. Since recently, in the recent past, we have also come across a lot of cases where the caller can be the abuser, caller can be using the content which is unwelcoming, sexual content to repeatedly by taking the number of a therapist. A number of reports have come in the media that how the telecounseling or such services have been misused by the people who have actually abused in terms of verbal abuse of the counselor or therapist. These cases have also come in the notice. So verification of client identity has to be done. NEMANS in the guidelines has talked about telepsychotherapy, and based on that they have talked about the in-person evaluation and also mentioned that there should be an RCA registration. However, in the telecounseling services, having many players from the TIS Institute in Mumbai, there are qualified clinical psychologists who are providing the services there, but the role is defined as a telecounselor or teletherapist. So this is a gray area in our country, which needs a lot of work to straighten it and to upskill. So when you're talking about upskilling, pandemic had seen the upsurge, and we on behalf of the Indian Association of Clinical Psychologists had also given the hotline in terms of helpline was provided where people could access, which was run successfully. And likewise, government has also given a lot of helpline, enhances the helpline. So this ran successfully. In fact, in the media, the reports came that there have been an increase of 60 to 70% people approaching for the mental health, panic attacks, anxiety, commonest presentation of such disorders during the COVID-19 pandemic. So you need to have a provisional diagnosis, the area you're working on, and informed consent should be obtained. Now you'll wonder how to seek the informed consent. Now there's a lot of benefits of taking the informed consent, because that will involve the payment procedure, and also the limitations can be shared. So if you have a documentation proof, if you have the process of interaction in terms of confidentiality issues, data security issues, no recording should be done, it should not be made available public, This should be a confidential information shared only with the therapist and the patient. These are some of the informed consent process forms. So we can send it via email and take it from the clients. There should be opportunity given to them to seek clarification from the therapist if needed before providing consent, and they can always call and explain that what this means. Once you have informed consent with you, this document becomes a valid document for even safeguarding the interests of both therapist and the client. What is the case handling? Supposing you get across a person talking about the suicidal or the substance abuse or the domestic abuse. So you need to have the emergency services numbers at your vicinity. Or rather, these numbers should be the one which you should be in contact with, that you should be provided these numbers for the help. Because such kind of services are required. People can call from the homebound situation, they can call from the where they are not able to access you. But if you have the services in place, you can probably give those numbers. So consultation, emergency services, this is known as escalation matrix. It is required to be in place. How do we go about it in the problem solving model? Define the problem, taking the priority problem of the client, that what he or she likes to address first, redefined by summarizing and understanding that this is what you understand, brainstorming with the client as to what is required during these sessions and the commitment of the sessions, and whether he or she can come on those days and particular time and have engagement on these sessions. Then about the option also, you can select if possible, it is recommended that they have an in-person contact with the telecounseling, but sometimes it is not achievable because by virtue of having this media, people can approach from the far off places where they're not able to travel. So this cannot be actually emphasized. So determine the client how or he shall have the selected option of working, and also summarize in the end that what you have understood, what you've communicated, what patient has understood, a client, I would use this word client here, has understood, so that both of you are on the same page on whatever has been discussed. There are strategies. One is problem oriented and the solution oriented. In the problem oriented, the questions are like, what is wrong, why it has happened, various historical causes are explored, counseling as a treatment or remediation has been taken. The various aspects have been used, like language, model, tone, pitch, aggression, emotion, etc., to understand the problem of the client. And solution oriented is what they want to change, what has happened, open space for future possibilities, and it assumes the client as a competent and resilient person, and it is a conversation which opens new possibilities and builds on client's ideas and language. So there is two ways to look at it. One is solution oriented becomes more effective, especially when you're talking about the counseling on a telephonic medium. So warn about the time, summarize the call, give the positive feedback, take control. In the termination of sessions, one has to use this simple like timeline firstly has to be discussed, and beforehand one has to be made ready that like any other therapy that we are going to terminate this session, let's say second last session, first session, and discomfort is also being shared. So there are certain challenges, I would say. They are known as based on the dealing with the disturbed caller. Some people just call out of disturbance of the emotional causes. So you have to you have to really amount of control you have to exercise in that option. Dealing with disturbed caller, again, you have to set the boundaries. And if there is homicidal or suicidal risk, then it is important that you give particular resources to contact a person. Then problem callers, like rappers, to talk without support, covert callers. They may use asking for help for another purpose or to help somebody else. Prank callers, like you have to really see that they are prank. They're just calling for the sake of one. Silent, they show acceptance and they're not debating much. Manipulators, they might just want something to be achieved. Sexually explicit callers are the ones who are basically is trying to be intimidated, and you have to have a lot of control and shut them up. And there may be some people who have the legitimate sexual problem. So this is important to handle these kinds of services. Extension of services, you should have the emergency note in your hand, detailed evaluation whenever required, and sessions in person when it is required can be informed. So need for emergency services, I'm emphasizing again and again, because one day somebody may call you that I'm going to hang myself, and then that is the time you have ethical responsibility that have give me the number of your close family member or the person who I can contact, because this becomes a moral responsibility and ethical responsibility. So clearly share the options, what is available with you, share the future transaction, navigation through the sessions, and at every age, whosoever is engaged, the clinical psychologist or counselor, they have to assess at every session that what has been the method of interventions. There are certain challenges like lack of control over the environment, confidentiality, therapeutic alliance, ethical aspects, and the adjustments to telephone level of psychotherapy. So what is required is there's importance to have the confidentiality issue ensured, no recording and no data sharing. So disable the recording feature on the tele platform if you have. Provision of telepsychotherapy requires the modalities has to be selected, and they should be informed about the possibility of unintended breaches of security and technology, so that they do not attempt to do any such thing which may come difficult at the later. So this can be a psychological first aid or the first order intervention. It cannot replace the therapy. Training of nuances is very much required in the telecounseling, and upskilling is required for anybody who is doing it. So there's a constant need of supervision and training in this domain, which I feel is lacking to a certain extent. So this is a need of an hour. Thank you. I kind of rushed through. I'm done with it. If any questions, I can answer the question.
Yeah. Thank you very much, Dr. Kalpana. That's
I was warned by the organizers of the time constraints, so I was on express speed.
No, you finished right in time, and it is an extremely comprehensive, very succinctly put telecounseling, SOP sort of protocol. Very nice. I don't see any questions actually. And I think Dr. Vinay Kumar unfortunately doesn't seem to be able to unmute himself. Okay.
Jyoti, let us go to the next.
Yes. Paper. Okay, sir. So without any ado, we can go to the next speaker. It's Dr. Professor Ajit Awasthi. If his CV can come on screen. He will be speaking on family and mental health of industrial workers, impact, role, and contribution.
Yes, ma'am.
Thank you,
Dr. Professor Ajit Awasthi is former head and professor at the Department of Psychiatry, Postgraduate Institute of Medical Education and Research, Chandigarh. He has been the past president of the Indian Association for Geriatric Mental Health from 2017 to 2019 and has been the chairperson for the Indian Psychiatric Society Research and Education Foundation. He has been the past president for the Indian Psychiatric Society and the convener from 2003 to 2009 and co-chair for the Task Force IPS Clinical Practice Guidelines. He has over 400 publications to his name and has funded 40 research projects. He has edited 16 books and contributed to 60 chapters in different books. He has delivered more than 450 scientific lectures and has 41 awards and orations to his name. His research interests are in schizophrenia, anxiety and mood disorders, human sexuality and its dysfunctions, and consultation in liaison psychiatry. Thank you so much. May we please request Dr. Professor Ajit Awasthi to commence his speech.
Well, thank you very much. Actually, I had decided to not deliver any talks after I superannuated from my service in PGI. But then the invitation that came from Dr. M.S.V. Raju, I could not refuse. My co-presenter, Dr. Swapanjit Sahu, and myself we both dedicate this talk to the memory of Dr. Shiva, son of Dr. M.S.V.K. Raju, a very promising psychiatrist whose life got cut short because of the will of God, and also to his very illustrious wife, Professor Alka Pawar, who has been, head of psychiatry in a very prestigious institute in Pune. And we pray that their souls find their final abode at the lotus feet. I am sharing my screen, but I think the control with you is not allowing me to.
No, sir. You can share, sir. We are just going to remove our screen, sir. You can now share your screen.
Now I can share.
Yes,
that's right. I'll come to a little bit. I hope now it is visible to everybody.
No, sir. Your screen hasn't been shared yet. I'm really sorry, sir. We can't see it.
How is that possible? I did share the screen. That is why I talked about the glitches at that time.
That's okay, sir. We can wait, sir. No problem.
Is it with you now? No?
No, sir. We can't see it yet. So if you wish, we can also share the screen.
Just wait
yes,
a minute.
Sure, sir. Sure, sir.
Just wait a minute. Can you give me just 1 second, please?
Please, sir. Take your time, sir.
Is it now?
Yes, sir. Yes.
There
now
in front of you?
Right, sir.
Okay. Is it there now with you?
Yes, sir. We can see it, sir.
And you see it now?
Yes, sir. Yes, sir. We can see it, sir. Thank you so much, sir.
Thank you very much. Well, I first of all extend my thanks to the chairpersons, as well as for me to be invited to present this talk at this time. And as I told you earlier, I think this is going to be one of very few rare talks that I'll be delivering in the rest of my life. Well, coming to the impact, role, and contribution in providing care of the family and its impact on their role and contribution in the mental health of industrial workers. This is the title of our talk. And if we look at
Sir, we are sorry to interrupt you, sir, but we are not being able to see the presentation. We are just being able to see the screen of your email address, sir.
God, why is it so?
So, some minor glitches, sir. So we can wait, sir.
Can you just then share my share screen from my side?
Sir, may I just suggest, sir? Good evening, sir. This is Dr.
Good evening, dear. How are you, Kalpana? Fine. I heard your talk. It was excellent.
What I said is, sir, if you just close this and open a presentation on your laptop, it will show. Close this.
Okay, I closed it. Now I am there with you.
It is not exit yet.
Your screen sharing is paused. That is what somebody is saying.
Sir, yes, sir. You will need to resume your screen sharing, sir.
I have resumed it. Is it with you? Can you see?
So we are just being able to see the page of your email address, sir.
You have to come out of that email.
I don't know.
I think you minimize this window, go back and just switch off, come out of the email and open the laptop, the presentation.
I had sent my...
Yes, sir, it is with us, sir. Do you want us to share it?
This PPT to you.
Yes, sir, it is with us.
You can share it if you want.
Yes, sir.
Please share it.
Yes, sir, right away, sir.
Is it there?
Yes,
I
sir.
can
Now it
see
is.
something.
Yes, sir.
Yes, sir, it's
but
visible.
it is visible now.
Yes,
Yes,
sir,
sir.
it's visible.
But then how will I change these slides?
So whenever you end any slide, you just have to say
Just say
next slide,
next.
please, and we will
Okay.
follow, sir.
Okay.
Yes, sir.
Thank you. Thank you. We
Not at
go
all,
back
sir.
to the old mode. Next, please.
Yes, sir. Yes,
And
sir.
I'll hurry up now. Next, please.
Yes, sir.
Well, my friend, no, this is not right. Please make it full screen, you know. No, you're not sharing it properly, please.
Sir, that facility is not available on our desktop, sir.
Then let
I'm
me
really
do it
sorry.
myself. I'd exit the full screen and then I will come to you, you know, in a
Yes,
minute.
sir. Sure, sir.
That will be better. Problem is that somebody is saying your screen sharing is paused. I don't know why it says so. Is it visible now? No?
Unfortunately not, sir. We can still just see the email address page, sir.
You can see the email address.
Yes, sir.
Then why can't you see this?
So I believe it's paused, sir, the screen sharing. So if you could just resume it, sir.
I'm resuming it.
Yes, sir.
Is it visible now?
Yes, sir. It is.
Yeah, it is visible now.
Perfectly,
Yes,
sir.
sir. Yes,
Thank
sir.
you. Thank you. Thank you. At long last. Well, as we all know that, but there is again some problem with this because it's not coming through properly.
So on the top left side of the page, the fourth icon from the left, if you just press that.
Sir, can I help it by sharing from my screen?
Yeah, please do help. Do help, Sabrajit.
Yeah, just give me 2 minutes, sir.
Okay. My friend is already here, so he will take care.
That's great, sir.
He is more computer savvy, you know. Swarpranjit, could you do something?
Yes, sir. Yes, sir. Just a minute. Because I have logged in here from the mobile, so I'm trying to do from the desktop. So give me a minute. Sir.
So may I just suggest that on the top left side of your page, the fourth icon from the left, so if you press that, sir, the slideshow will start. Not that one, sir, that's the right side. On the left side.
From beginning. Right
Yes,
here?
sir, that one, sir. Yes, sir. Yes,
Is it there?
Yeah.
Yes.
Okay, sir. It's done.
It's done?
Yes, sir.
Yes, sir.
Yeah, there it is.
Yes, sir.
At long last. Okay. Thank you very much. I'm very sorry for this glitch, and I think I will proceed now with the presentation. Well, friends, we are all familiar with the WHO definition of mental health, and that talks about that every individual has to realize his or her potential, should have the ability to cope with the normal stresses of life, but more importantly, in the context of the present presentation, they can work productively and fruitfully. And I think that is the key to this presentation, whether the workers in any industrial unit can work productively and fruitfully, that will define to a certain extent their state of mental health. Well, the workplace and the mental health of workers have a very complex relationship. And As we can see, work has a very positive impact on the mental health for all of us. We are all appreciative of it. It provides us job security. It helps us to structure our time. We do develop social contacts, and the organization abilities can help us to improve upon our state of well-being. Nevertheless, there can be very adverse impacts on the mental health of workers because of the excessive work or a work which is disruptive, and it can decrease their productivity as well. In any organization, the workforce is the biggest asset for that organization. Often we talk of the infrastructure, the management of the infrastructure and the machines and so on and so forth, and the markets and so on. But actually everything flows from what the workforce intends to do there and is able to accomplish. Without a mentally healthy workplace, the team of workers will experience low morale, they will be very stressed, very anxious, and they will have an increasing load of physical health problems, and their sickness levels will rise. Resultantly, the productivity will drop, and the organizational atmosphere will be very adversely affected. Therefore, a mentally healthy workplace is one which is seen as a very happy and friendly place to work. It is akin to the family place, where if the family is happy and you have a friendly atmosphere in the family, you tend to get a lot of things out of it. Whereas if it is stressful, then we all know that our lives do get affected very adversely. So therefore, for any high productivity levels to be achieved and to achieve the efficiency levels, it is very important that there should be a very open discussion about the mental health issues in any organization. Now, what are the problems at workplace? There are certain risk factors for poor mental health of workers. There are two types of stressors which industrial workers go through. One is the job demand stress, and the other is the job control stressors. And both these kind of stressors, job demand and job control, they lead to a lot of stress at the workplace. Now, as far as the job demand stressors are concerned, these can be because people don't have the regular employment. They have, contracted outworks, which do not provide job securities. There could be fragmentation of the responsibilities at a workplace. There could be infrastructure difficulties in terms of crowding, poor lighting, fear of accidents. There could be forced overtime. There could be a pressure from the management to work more, to accommodate more. The shift works may not be very, very congenial for the total 24-hour life of a person. There may be even a workplace violence. There may be indiscipline there, favoritism, and our people are some kind of burdened with unnecessary paperwork, which they perceive as unnecessary, and then it becomes too much of a demand to handle. At the same time, there can be job control stressors also. It could be that you are not recognized in the organization. Job insecurity I've always referred to. There could be harassment. Supervisors are very harsh, very brute. They do not respect the low-level workers. There could be quite a lot of racism, sexism, or age discriminations. There could be inadequate pays, which become a major issues at times. Or there could be no scopes of promotions or upward progression in their workplace. And hence, it leads to a plenty of job stress at the workplace. Now, the next issue which is important for us to consider is that why mental health matters to begin with at the workplace. We are all cognizant of the fact that the job stress can negatively affect one's mental health. Therefore, it can lead to a lot of errors, which can lead to accidents, injuries for the workers, or even the errors in production, and hence the whole lots which have to be sold or marketed or to be put in the the marketplace. Those will get affected and may get rejected. It impairs the relationship with co-workers and seniors, and inevitably what we find is the outcome is the increase in substance use to alleviate stress. Plenty of evidence is there for increased smoking and increased use of alcohol and even other substances by the industrial workers. All this will lead to a very high degree of absenteeism. There will be a job loss and unemployment, and which will, when people go for the next jobs, they do not get the right jobs of their preference, and hence there is a dissatisfaction with the workplace and the work they are doing to begin with. Now, mental health and work performance is very positively linked with each other. There is enough evidence now to suggest that of all the mental health problems, depression in workers is one which greatly impacts negatively on their time management and productivity. There is also sickness presentism. And when we talk of sickness presentism, we mean that people are physically present, but they are cognitively or mentally absent. So they are not putting in their best at their workplace. So there is a strong association when these kind of problems arise that people will present with pains, fatigue, depression. This is a predictor of the future poor mental health, and not only mental health, but also a poor physical health as well. Now, we always find some kind of a relationship of problems with superiors, to relationship with co-workers, to performance pressures, to poor job prospects, and then it impacts the family. And once the family gets affected, it in turn leads to all these problems in relationships and performance and so on and so forth. Therefore, at the common workplace stressors could be interpersonal conflicts, there could be disorganization in the workplace, multitasking demands, or even the physical discomfort because of the infrastructure limitations. Therefore, the big question which comes to us is, we understand that the worker gets affected, but can industry affect the family of the workers? And that's the big question in front of us, and let's see how we address this. It has been seen that the process of industrialization has disrupted our conventional notions of families and the expectations of roles and responsibilities for each member in the family. The 19th century industrial workers' families were relatively large families, where women tend to have children, more number of children. They were the motivation to limit the family size was low. The children often contributed to families' income and household activities and provided a lot of respite to the adult members. There was less working females in industries. The females were there to support their partners who were out working in the industries, and they would take tasks which were there necessary to manage the household. And hence, in some way in this job distribution and in this role distribution, there was some degree of harmony which was there even in poverty, and there were more cohesive families. With the 20th century rapid industrialization, the industrial workers' families have changed. These have become relatively much smaller families. The workers often stay away from families. In many of the situations, they may be away from their native villages and working in urban areas alone. They have no family to fall back on or to return to. Women tend to have limited number of children. There is, children are dependent to quite a considerable degree of their age on the family's income. We have more working females in industries, and there are more monetary demands from the family members in terms of the education of children or the amenities which are required in children, hence more needs, and workers who are the members of family who are working, they are in more demand, they have a more demand on themselves to bring more money at home, and hence have to work more and more. So families are struggling to cope with an increasing complex world. The individuals are struggling to find the right balance between work and family responsibility. And inevitably, this leads to a lot of domestic issues which affect work. And because the families are not at rest, families are not at peace, the workers are not at peace at their workplace. Now, the work interferes with family life, that we all know, because there could be extensive or inflexible work hours. There could be interpersonal conflicts at workplace, and are the unsupportive organizations, hence they bring their problems from their workplace to their families. Are the vice versa, the family discord could interfere with work life because there are young children who have to be taken care of, there are elderly who have to be taken care of, and there are interpersonal demands, interpersonal conflicts and stressors, and at times the family members are perceived to be highly unsupportive, and hence the workers may need more time to give to their elderly or children in the family who may fall sick or who may have problems which need to be attended to. Therefore, there are a number of interacting variables like work domain variables. There are non-work domain variables which have been lifted, and there are certain demographic and individual variables like the income, the sex of the worker, the kind of coping styles and skills they have, and hence there is an interference in the family atmosphere and relationships, as well as the family interference with the work. Not only that, when we focus on the work-family conflict and try to understand it, we find that the objective social environment not only takes care of the organizational and the workplace problems, but it should also take into account, while we're assessing it, the family relationships also. Same is true for the psychological environment, and as far as the person's evaluation is concerned, we also have to take care of his affective state, his psychological state, his degree of the health soundness or illnesses which he is prone to, his satisfaction with his own self and other personality characteristics, and hence inter alia this will have a tremendous effect on his behaviors, which are determined by his coping and defense mechanisms. Well, friends, the family and industrial organization have a very intrinsic interaction. We have enlarged upon this point in more than one way, and hence what we can summarize is that the workers are often stretched between the families and their workplaces. Hence, they get inadequate time for attending to their child responsibilities or supervising their children, and there is an unfulfilled needs. There is an increased demand over their time. They are often dissatisfied with the kind of earnings they have, and that leads to increase in psychological distress. We have also stressed on this that the industry can be impacted by poor performance, low productivity, and even employees' turnover may be affected. Whereas the workers are impacted by the reduced job satisfaction, they may be psychologically distressed and may have poor life satisfaction. Having emphasized that point time and again, let us see how it translates into economics. And it has been seen that it in fact turns out to be a very unsound financial proposition for the industry if their workers remain so stressed and unsatisfied. In a survey done in the United States, the 32% of employees reported that they were having a major problem with balancing their work and family demands, and hence they were in major stress, and that was leading on to low productivity of at the workplaces. In the South Asian countries also, the same kind of problems are being seen, and actually the male workers are now finding a lot of competition from the female participation at workplace. Now this has led to not only the changing family role expectations, but also a competition to secure jobs at the workplace for the male forces. Now, there are certain problem statements, and that is that there could be late attendances, absenteeism, increase in alcohol or substance use, mental disharmony, individual psychological distress, overall decrease in productivity, and also an increase in industrial costs or low returns to the investments which the people have actually invested in industries individually or collectively. Now, can family help in improving mental health of workers? That's a very good idea, question, which would come to anybody. We may work on the workers, we may work with the organizations, but is there any point in working with the families of the workers in order to improve upon their performance and getting increased productivity in industries? Yes, it has been unequivocally now proven that family can play a major role to assist in identifying psychological distress in the workforce. They can also provide mental health care and support. They can go a big way in reducing the psychological distress of the workers, and it can act as a wonderful bridge between the worker and the organization. And we will see all this. Now,
Sir,
yes.
I just want to say that there is just a couple of minutes left on the
yes,
schedule.
I'm about
but
to
you
finish.
can continue. You can
I'm
continue.
about to finish.
Yeah.
So
thank you.
There are telltale symptoms of psychological distress in a worker, which the family can pick up very easily. They can find that there is a decrease in personal hygiene. There are frequent complaints of unexplained pain. The worker appears at home confused, distracted. He has, he excessively talks about his problems at workplace. He has disturbed sleep and appetite. His social interactions are restricted, and even he has cognitive disturbances, Now, they can also find that not only that, but they are giving blank stares. They appear to be lost. They have unsteady gaits, red eyes, tremors, and at times even symptoms like vomiting and other things which can be there. So family members are very helpful and can be the first contact to identify such changes in workers' behaviors. They can also find more injuries, accidents when their family members are meeting those at the workplace, or more problems which they express, increased errors which they make at home while doing household works, and they appear to be rather disinterested in work and family, and often spend more time outside the family rather than at home. Therefore, they will be identifying such indicators of decreasing efficiency at workplace too, and can alert the organization whether the family member is having some problems at the workplace as well. They can provide support, we all understand it, and this support is very important because they spend a lot of time with them outside the workplace, and they can boost up their confidence. They can assist them to recover from any mental illness or addiction problems, and they are known to provide unparalleled and selfless emotional support. So therefore, the role of family is there in treatment compliance also if they have any major psychiatric issues. Also in the rehabilitation, they can play a major role. And not only that, but they have a much larger role, but they will do need from mental health professionals some guidance in fulfilling these roles. And therefore, the mental health professionals have a lot of responsibility to focus on the families of the workplace, workers, so that they can intervene at that level, equip them with certain strategies and capacities, so that they can, the families can play that role effectively, and hence lead to a better mental health of their family members, which in turn can get translated into a true partnership between the worker and the industry. Therefore, there are certain upcoming and ongoing issues with regard to the family structure in India. We are going through this inevitable process of urbanization and industrialization here. It has as its impact on our traditional notions of families. There are increasing numbers of unsupported nuclear families. We have a lot of financial deprivation and stress on these families. There is problems compounded by chronic illnesses and alcohol dependence. We have more elderly persons to be taken care of, and there are high rates of unemployment, which compound the problem further. Therefore, we need to establish a very healthy work-family balance, work flexibility, participating in family wellness care units, which each industry can establish, reducing work-related stress, talking to the organizations and the people who manage those organizations, and this providing some kind of forum with the family members at the workplace, so that they can come and discuss what role they can play to improve the performance of workers at the organization. Therefore, we need to develop very empathic feelings as well as supportive attitude to take care of this problem. Regular health screening, creating awareness, and incentivizing the workers to build their home in the areas of the workplace, as they call it, will go a long way in solving this particular problem. Therefore, in the end, to conclude, it can be said without doubt that the common mental health issues and psychological distress is quite prevalent. Families do get affected. Family members can play a very important role in alleviating the problems of workers at workplace. They should be provided with a lot of awareness, and their capacities should be built up to, work with the demoralized mental health workers, and they have to act as a buffer to de-stress the workers. Therefore, what I can say towards the end is that the management should take upon itself a responsibility and role to liaise with families of co-workers to promote mentally healthy workplace and reduce work-family conflict. Thank you very much.
Thank you, sir. That was an extremely exhaustive and most complete presentation. Thank you very much. I don't think there are any questions. So can we finish the session here today? I understand there's an AGVM after this.
We are extremely grateful to our respected chairpersons, Dr. Jyoti Shetty and Dr. Vinay Kumar, for presiding over this session. We also extend heartfelt thanks to our valuable speakers for the enlightening sessions and the new perspectives given to us today. We shall now proceed to the annual general body meeting. Kindly log in using the link which has been sent to you via your email. We humbly request non-members of the Association of Industrial Psychiatry of India to exit the room. Live streaming will be henceforth halted. Delegates may proceed over to room 2 for the ongoing sessions being held there. May I now request Dr. Jaideep Patil to kindly conduct the proceedings from here onwards.
अभी आएगा